should be able to recognize the radiographic findings associated with hiatal hernias. For example, sliding or axial type hiatal hernia. And you notice part of the stomach is just above the diaphragm right there. You should be able to identify the other parts of the stomach. Okay. Here's the corpus antrum bulb, and you can see the bottom of the stomach. Another pattern of herniation is the paraesophageal slowing hiatal herniation. Again, the diaphragm's running right here. In this case, you've got part of the greater curvature of the stomach running through the esophageal hiatus. So you should be able to recognize different patterns, axial, paraesophageal. Okay, normal radiographic anatomy of the esophagus. I'm going to identify the LAS as the LAS. Proximal stomach here. You should be able to recognize the radiographic findings associated with achalasia. Achalasia presents with a dilation of the esophagus proximal to the LAS. The LAS is right there, and proximal you can see the esophagus is dilated. You should be able to identify the Z-line. That's a radiographic term. It's simply the esophagogastric junction. And there's an example of filling defects caused by esophageal varices. Esophageal tube, it's an upper GI series. And you can see the normal esophagus fills uniformly. Smooth luminal surface topography. Over here you can see esophagus remarkable for esophageal varices, numerous filling defects. I don't believe we went over this in class, but just take a look at it. We looked at an example of a normal esophagus and upper GI, demonstrating the Z-line. There's the lucency of the Z-line, that's the esophagogastric junction. Again, you can see on an upper GI series, the esophageal walls are relatively smooth. You will find a kind of a corrugated architecture, but it doesn't really appear well on a radiograph. So the walls are very smooth. Over here, you can see an esophagitis. You notice the luminal topography is not smooth. It's remarkable for little crevices and intact parts of the esophageal wall. The intact parts of the esophageal wall presented here is this lucency. Little crevices and defects filled with barium, and you can see make these long radiographic streaks up and down the esophagus. That's typical of what you see for a severe esophagitis. Okay, this was a example of an esophageal squamous cell carcinoma. We're looking at the upper two-thirds of the esophagus. Again, proximally you can see smooth walls of the esophagus filled nicely with barium. Distally, same thing, smooth walls of the esophagus. In the middle here you can see a strictured area of esophagus that has a kind of a rough luminal topography. This is actually the surface of the squamous cell carcinoma changing the topography of the esophageal lumen. The mass is actually bulging out this way. You can actually just see it. It's growing in an annular distribution, and as it grows in annular distribution, it's encroaching on the cross-sectional area of the esophageal lumen. The surface itself is very rough, and so as a result, you can see a rough surface topography here in the upper GI series. Okay, we examined adenocarcinoma of the esophagus. Typically develops just in the distal one-third of the esophagus. Again, we have normal here for comparison. So looking at the distal esophagus, there is the distalmost portion of the esophagus. There is the LES right there. The esophagogastric junction is there. You can see that when the LES is closed, the esophagus kind of tapers smoothly to a kind of round point here. There's no irregularities. It's got a smooth contour. No abrupt changes. Over here you can see an example of an esophageal adenocarcinoma. Stomach is here, esophagus here, and the LES is right in this region. If you look in this area, you might see tapering you'd expect to find for the LAS, except that the contour of this tapering is unusual. You don't see the smooth tapering you do with the normal LES. Instead, you see these kind of rigid, kind of very sharp demarcations here. This is actually a stricture created by the adenocarcinoma growing again in an annular distribution. It's really stricturing the distal part of the esophagus. There are irregularities in the surface of the adenocarcinoma that allows for barium to kind of fill in little crevices. And it appears as though there's some barium overhanging the area you'd expect the LES to be in. This actually isn't the LES that's causing the stricture here. This is a cancer causing the stricture. Okay, we have radiographic appearance of benign peptic ulcer. Again, you can see the corpus of the stomach here. There's the antrum of the stomach right there. And if you interpolate the curvature of the lesser curvature of the stomach, again in this area you can see some barium here that seems to overextend the interpolated borders of the lesser curvature of the stomach, and that's again that's an area where barium should not be collecting. It's caused by a little crater in this area, and that's benign peptic ulcer. We have here one example, the radiographic appearance of a gastric cancer. Gastric cancer can appear in many different ways. This is the way an exophytic mass will be exophytic, X is going out, is going as a protruding mass. It's an exophytic mass. Again, we got normal over here for comparison. Corpus, antrum, and duodenal bulb. Again, you can see the corpus, the antrum, duodenal bulb here. You can see the corpus and antrum are filling uniformly with barium. There happens to be no food in the stomach. This GI tract was prepared, evacuated with all food, and so it all fills up nicely with barium. If there were food in here, you'd actually see filling. But there's no food in here, so everything fills up nice and completely with barium. Everything's nice and uniform. No filling defects at all. Over here, towards the distal corpus, you can see there's a filling defect. That's an exophytic mass. There. You also see a filling defect in the duodenal bulb. Over here, the duodenal bulb is filling uniformly with barium. Here, again, you see there's something there. And again, that's one example of how a gastric cancer can present. It's not the only way, but that's one. Okay, we're looking at lower GI tract. Do this in the context of inflammatory bowel disease. Should just generally be able to identify the different portions of the lower GI tract by radiographic barium enema study. So, what's this part? Cecum is over here. Just proximal. External ileum and that little stricture. That's ileocecal junction, and this. That's the ascending colon, and this little area where the large bowels attach is called that's the hepatic flexure, and transverse colon here. Splenic flexure, descending colon, and sigmoid colon here, and that is the rectal vault.
The rectal what?
Rectal vault.
Vault.
Everything else here is small bowel.
Vault.
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 Rectal vault. Okay, so I pointed out, normally you've got a A large bowel remarkable for Hofstra. Fluctuations in the caliber of the bowels caused by the Hofstra. Nice, smooth, luminal topography, and generally good caliber. Lots of slack, especially when the transverse colon. And you'd also see it in the sigmoid colon as well. Lots of slack in the sigmoid. Inflammatory bowel disease. This is an example of ulcerative colitis. You get lots of inflammation, causes lots of scarring. Scar tissue contracts, takes all the slack out of the bowel, makes it really taut. So we have here, again, the ascending bowel right here. We have the transverse colon right there. Instead of kind of making a lazy turn around here, going from the hepatic flexure to the splenic flexure, it almost goes straight across. There's just a lot of tension in this bowel. There's no slack in it at all. And it goes straight down. Caliber of the bowel is wrong. Caliber of the bowel looks stricture. That's because it's scarred down. All the slack is taken out of the bowel for the same reason. Bowel strictures, all because of scarring and contracting of the scar tissue. We see irregularities in the luminal topography here. We got filling defect here, we got a little wedge-shaped opacification here, another filling defect there, a wedge-shaped opacification there. Those little filling defects are pseudopolyps. Diverticulum. Again, another lower GI study. What do you think that is right there? That's the rectal bulge. Okay. And what's this over here? A small or large bowel? Small bowel. And of course you got that sigmoid colon. So you got sigmoid colon here. You can see a lot of Hofstra. And it seems like almost normal luminal topography, except you got these here. These are radiopacifications that seem to have, that just seem to be composed of blind ending chambers that communicate with the rest of the lumen of the bowel. Those are diverticulum. They're called button lesions. Neodense little button-sized opacifications are called button lesions. This right here, what is that? That's an abscess. It's actually what's happened here. You have a diverticulum, probably much like that. That ruptured, the contents of the bowel kind of spilled out into the pericollic fat, and an abscess as a result. Okay, so the scintillation scans on. You've seen a few of them. This is a scintillation scan showing you perfusion. You can do this a number of ways. You can radio label RBCs. You can dump colloid into the GI, into the vascular compartment, and then the radioactivity kind of distributes, and radioactivity increases when you have lots of blood. So, looking at this scintillation scan, you can see the descending aorta there, the inferior vena cava. You can see all different common iliac arteries and veins right in here. Okay. Kidneys right there. It's a highly vascular organ, so you can see lots of blood flow. Okay. These dark areas, are they highly radioactive? Or are they more radioactive than these light areas? Which area is more radioactive? This or this? The dark area or the light area? Dark area is more active. Right. That's where the activity is accumulating, so naturally that's where the RBCs or colloid or blood or whatever you want, whatever is radio labeled there is. Doesn't give you a pretty picture, but it does give you a functional map.
Dr. Madden, sorry to interrupt you. Are the radioactive RBCs from transplant blood or a person's own blood?
You generally take some of the person's own blood and you incubate it. So there's no problems with, auto transfusions. You can do that. If you know you're going to have an operation that's going to require lots of blood, they can give you what's called an auto transfusion. So maybe a month or two before you get your operation, they'll take your own blood. And then you'll replace that blood and you'll have this extra blood. Good idea, because as good as we screen, blood, there's a lot of problems. Big theory is it's considered a risk. Okay, again, this is a whole GI series, it actually began as an upper GI series. You know, then you can see the stomach up here, and you can see just lots of loops of small bowel, that's all there is here. A lot of filling defects due to the plate circularity. You should be able to tell the difference between large and small bowel on a radiographic study. Okay, lots of distended loops of small bowel due to a bowel obstruction. You can see the small bowel because it's filled with barium. And at this point, you see there's an abrupt, there's a point where you can't abruptly visualize the bowel anymore. This, of course, is where the obstruction is. No barium can pass this into the obstruction. So you can see that most of the bowel here without barium is going to be pretty radiolucent. You're not going to really see.
On the previous normal, why did you see large bowels? Like the transverse column,
It hasn't done there.
or just the very hasn't done that?
So this was probably a barium swallow.
Very interesting.
You eventually the person will pass it.
Here it's small bowel, yeah.
So you just took the X-ray before it not showed up.
And you'll have to time it well, because if you really want to see stomach and upper GI.
Yeah.
Otherwise, you'll have to keep administering the
We
barium.
didn't talk about
Okay. And you're just looking at a radiograph without any contrast agent at all. Can you tell me if a GI tract is mechanically obstruction or functional obstruction? Okay, and this bowel is mechanically obstructed. Mechanically obstructed, see the air fluid interface is here. Alright, well, the only reason you can see this loop of bowel is because it's filled with air, and air acts like a contrast agent. The rest of the bowel is filled with stuff, probably fluid. And it's just blending in with the rest of the soft tissues there. Fecal material, it doesn't have any air in it, it could be collapsed. This has lots of air in it, so it's acting, air itself is acting like a contrast. Okay, that's not the best example of a volvulus, but it's called the inverted U sign.
Right.
And you're looking at a radiograph of what you see right here. Okay, so there is a loop of bowel, it's twisted on its base. There's the base. There's the bowel, it's over there. Called the inverted U sign. You can't see the whole inverted U, but it's called the inverted U sign. Not a good example. Okay. Can you recognize a double contrast study when you see it? Can you recognize a single contrast study when you see it?
Wait, why is this a double contrast?
Double contrast. Two contrast agents used.
Because you see the very light and then just a little bit light?
Well, there are two contrast agents used. Barium and air.
Okay.
So, procedure. Give barium enema. Okay. Usually you go ahead and take a radiograph with barium in there. Then you ask the person to evacuate, and then you just inflate the bowel with air. And the second contrast agent is air.
So the light one's on this side is air, and that one's the barium?
This part of the bowel is mostly occupied by what?
Barium.
This part of the bowel may be coated with barium, but it's mostly filled with air. The trick there is to just coat the surface with barium.
Okay.
And you can see a lot more surface topography, you just coat it with barium. Gives you that pseudo 3D look. And inflate the bowel with air. That's a double contrast agent. What's this thing here? What's this bowel doing here? This is a sigmoid colon. What's going on here? Why is it so structured here? Hmm?
It's twisting,
It,
it's
it,
like wobbly.
a volvuli usually develop in this area, because exactly that, you got a loop there, demonstrations to form. Any reason why it's stricter here?
Is there any vision?
An adhesion. Can't tell if there's an adhesion on the, on this radiograph. Could be an adhesion, but, you mean like a whole, like an internal, herniation? No. Any other reasons you could think of why it's strictured here?
It's like a hose, you know, when you have a hose and you turn it
Oh,
on.
and you kink it, yeah, kink in the hose. Yeah. Any other possibilities? I told you this bowel was normal other than the polyp. It's there's a lot of redundancy in the sigmoid column, but the strictured area, why is it strictured? Peristaltic wave? Normal peristaltic wave. What kind of polyp is that? Gross morphology. Concentration? Pedunculated. Here's a single contrast study. A redundant sigmoid column here. Okay. What's that? That's over here. What's this? That's a terminal ileum. And this little thing? Yeah.
Appendix.
And, okay, and this? The wall. What's this?
Gas.
This is gas. This is air. Okay. Wow, look at that. Redundant sigmoid. Filling defect. How would you describe that filling defect? Apple core. Yeah, it's a cancer growing in an annular distribution.
What was that called?
Apple core. Apple core lesion. Or apple core filling defect. Okay, that can transit. You identify different parts of the GI tract. Make sure you know you're looking at different contrast agents. Shouldn't be too bad.
100 AM concentrations you talked about at Aaron.
Yeah, air and bearing. Aside from, IV, iodine based. Okay, so we're ready to proceed with the accessory GI. Any questions about upper and lower GI? So moving on to a different topic now. Should be comfortable with upper and lower GI. Questions? Now, first accessory organ we're going to talk about is the appendix. And we're going to talk about the inflammation of the appendix. Just a couple of epidemiological correlates. 1 in 10 people are gonna develop an appendicitis over their lifetime. If they're going to develop an appendicitis, usually they do so earlier in life. Many exceptions to that, usually in their late teens, early 20s, if someone's gonna develop appendicitis, that's when usually they develop it that early because there's something a little different about that type of appendix. Most cases of appendicitis are caused by luminal obstruction. And if someone's going to develop a luminal obstruction, usually the appendix has to have a very narrow lumen to begin with. Maybe if it's easily obstructed, it will be obstructed early on. Typically, what happens with an acute appendicitis is that something obstructs the lumen. It could be anything. Sometimes it's a piece of hard stone. Sometimes it's a gallstone that's caught in there. Sometimes it's it's one very large nut or something that's caught in there. Sometimes tumor grows in the appendix. Carcinoid tumor is a good example. Sometimes parasites will infest the appendix. Sometimes inspissated barium enema will get stuck in the appendix. Whatever happens. Usually some identifiable obstruction of the lumen. Lumen obstructed bacteria within the lumen contain